It's the appointed time, so we're going to go ahead and get started. This is the Clinical Ethics Consultation, Process and QI, or Nuts and Bolts session. So my name is Zane. It's been a really rich day of conversation. I hope you've enjoyed it. I'm going to just briefly present our presenter and then turn things over to him. Our presenter for this afternoon is Dr. Jukes Namm, who is an associate professor of surgery here at the university, at Loma Linda University. He's also the program director of the general surgery residency. He works as a surgical oncologist, a clinical ethics consultant, and has written and presented on the history of surgical ethics, medical innovation, and resource distribution. He also yearly conducts lectures to medical students and residents on ethics. So we're really glad to draw on his experience today. If I understand the plan correctly, he's going to present for about 45 minutes. And after that, we will open things up for some question and answer and group discussion. So Dr. Namm, thanks so much for joining us today.
Thanks so much, Zane. Thank you all. So as a quick disclaimer, as Zane pointed out, I am a surgeon. A rare breed in the kind of ethics world, but really have been privileged to be able to be a part of kind of the ethics team here at Loma Linda. And I was able to do a fellowship in clinical ethics during my time at the University of Chicago, where I got my surgical oncology fellowship. But it's I think this is a good presentation to follow up on our last presentation, which I think was really fantastic. But I'm going to kind of give you a little bit more kind of practical tools and tips and tricks in terms of how to maintain and improve upon the clinical ethics committee consultation service at your own institution. And I would say that I cannot take credit for most of the things that I'll be presenting today. A lot of my predecessors and my kind of colleagues have really work together on the things that we have put together here, and hopefully, I'm happy to share any of these resources with any and all of you who are involved in clinical ethics, who are wanting to start kind of clinical ethics or get involved in that or lead a clinical ethics committee at your institution. So, and I look forward to the time at the end where we can maybe share ideas. And kind of build upon what you are all doing at your institution, because I think all of us are here because we share a common mission and purpose in what we're doing, and it's really a blessing to be able to come together as kind of Adventist health system in general, but also those of us who are really passionate about ethics and providing high quality care for the patients that we serve and the communities that we serve. So, I really want to talk about ethics quality, right? And so quality has really been a buzzword in medicine and healthcare. But I think in terms of ethics quality, it's very different from medical quality. Medical quality has to do with procedures and outcomes and maybe some financial kind of issues, right? And as we heard earlier today, ethics quality sometimes goes against the grain in terms of all of those. But really, it's just as important, if not more important, because it has to do with ethical standards, norms, expectations that our society, our community has of us as an organization to maintain that trust in caring for them and their loved ones. And I think we, as an Adventist kind of collective, we have guidelines, we have statements and position papers through the church and through our hospitals and policies to help ensure that we maintain high ethical quality standards. So as was mentioned just in the earlier session, we talked about the Joint Commission and how in the most recent kind of iteration, they removed some of the ethics requirements from Joint Commission accreditation. But due to protest, there was a review of those statements, and I heard that it was placed back in. I haven't seen it for myself, but I wasn't surprised because I think to really run a quality healthcare system, really need ethics on board to run in parallel with patient care, and I think it goes hand in hand. So in terms of ethics quality, there really are three levels that I wanted to kind of share with you all today, right? And due to the short time, we're going to really just scratch the surface on all three levels, but hopefully it'll give you an overview and also leave you with some practical tips on how to address and improve on each of these levels. So at the top, in terms of the tip of the iceberg, is where maybe most of us in this room are involved, which is the ethics consultation service. That's where actually decisions have to be made and action needs to be done for specific patients and patient care. And that's, it requires some resolution within days or weeks or months at times, as was the case that we discussed as a group. And then underneath the surface are what a lot of us may not see, what patients may not see, but equally as important in terms of preventive ethics. And it's something that actually Dr. Yu mentioned in the last session as well. What can we do to kind of ensure systemically that that we mitigate ethical issues or dilemmas, and we ensure that quality patient care is delivered? And that has to do with policies, processes, guidelines, and structural support. And then way deep at the base of this iceberg is ethical leadership on an administrative level, as on an organizational level. What can we do to help shape and guide the culture of ethics within an organization, not just to be a rule following organization, but people who live out kind of our stated values. And that is a lot harder to do. And I don't have any easy answers for that, but it takes time, it takes leadership, it takes culture, and it's like trying to steer the Titanic, right? It takes a long, long time and a lot of effort, but it can be done. And so it doesn't mean we should give up. So I want to start on the top of that iceberg. So in terms of ethics consultation, and I think, the last session, we really dove in nicely in terms of the process of ethics consultation. So I'm not going to spend a whole lot of time regarding that. But I think one approach is kind of the cases approach, and probably similar to the approach that many of you take in terms of, clarifying the request, assembling the relevant information, both the medical and the psychosocial, cultural issues, synthesizing the information, and then kind of give a discussion in terms of what's the key stakeholders are, what the ethical issues are, and then making a recommendation, right? And then supporting the stakeholders through with those recommendations. But I think the purpose of ethics consultation really is to make sure that from case to case that we maintain these high ethical standards. It helps really foster consensus. And I'm sure those of you who are involved in ethics consultation know that I think 90% of what we do is just facilitating communication, right, between different teams, different stakeholders, resolving conflicts, and then also honoring the participants' authority. So both the patients and the families, as well as the medical team or the staff who are taking care of the patients. And then also educating the participants. Again, educating the family and the patients in terms of maybe helping them to understand the medical side and what the medical team is trying to inform them of. And then also educating the medical team in terms of what the patients and the family's cultural context and wishes and values may be. So I think, with any good ethics consultation service, I think it really, you need good ethics consultants, right? And I think depending on what institution you're at, you might be the sole ethics consultant caring, for the whole hospital. Or here at Loma Linda, we're fortunate we have a team. We have currently 5 ethics consultants, but that waxes and wanes over the few years that I've been here. And we can kind of work together and discuss cases as well. But I think overall, as an ethics consultant, you need to have a good background on ethics and the principles of ethics theory. You need to understand the ethical issues and concepts in medicine, such as shared decision-making, end-of-life care, privacy, confidentiality, professionalism, resource allocation, justice, even research, and even business and management. You need to have some sort of clinical literacy. You don't have to be a physician per se, but really be able to understand the language and the communication, both to the lay people and to the medical professionals. You need to be sensitive to cultural and religious issues. You need to understand the healthcare environment and how that has been rapidly changing over the past years. You need to understand the organizational structures that you're working with as well. If you don't understand that, then it's very difficult to make a lasting and important change. And then finally, you need to understand health law as well. And so if you look at this list of things, I don't know how many of you are experts at all of these things. So I definitely, we have one. So I definitely am not. I don't know anyone who is, but that's a lot to ask for one person to be able to adeptly manage. And so I'm still learning every day and every week that we have clinical ethics consultation service. And I'm blessed that we have a whole team with different areas of expertise that can shed light and give us different perspectives on the case at hand. So as was mentioned earlier, there are different models for a clinical ethics consultation service. So there's that individual model. There's a committee. You just kind of discuss everything in a committee. And then there's a consultation team, which is probably the most common out there. And there are strengths and weaknesses of all three models. Individual model, certainly a lot of flexibility. You can probably, get to things a lot quicker and maybe, get recommendations in a lot quicker, more flexibility, but you're one person. And so there's limitations there. You may not have all the different perspectives. You may not have the expertise or even the bandwidth to handle the load of ethics consultations that may be required. Committee, you have a lot more people, a lot more, experts in the room, but it could be a longer process to get things going. You can't meet, within the same day many times. It may take days or weeks to assemble the committee. And then the consultation team, again, I think it's kind of the best of both worlds. And here at Loma Linda, we have a weekly clinical ethics case conference. We have an individual consultant who is on call for the entire week, and then they present the cases for the week at our conference, where we discuss together, give feedback. And it really is a great environment to discuss and improve patient care, but also it's a venue I'll talk about later where we spend a lot of time on education. So we have students and non-ethicists who are there and really fostering this learning to hopefully mentor future ethicists. So those of you who are ethics consultants, we have a credentialing process here. And I think from hospital to hospital, there's no set kind of guideline or set criteria, but we do have a credentialing process. And our ethics consultants come from a wide variety of disciplines, which I think is a strength. So we have internal medicine, pediatrics, critical care, family medicine, palliative medicine, nursing, surgery, surgical oncology, psychiatry, represented in amongst our consultants. Most, if not all, have had a master's in bioethics or have been fellowship trained in clinical ethics. And most, if not all, have gotten certification through the ASBH Healthcare Ethics Consultant pathway or in the process of doing that. And there are a lot of great resources through the ASBH to do that. And I would say those of you who have been practicing clinical ethics consultants for at least a few years, I'm sure you've seen pretty much all that you need to know to be certified as a through the ASBH. I think they cover just kind of the bare minimum of what clinical ethicists should know. But certainly I've learned a lot more just in the day-to-day clinical ethics consult service, more so than studying and preparing for this exam. We also have community members who are part of our team, and again, provide really valuable perspective and feedback, and bring about things that we may not consider or may not have thought about as clinicians or medical providers. So I think a big hurdle really is, how do you reimburse our clinical ethics consultants, right? I think we all in this room, I think I'm speaking to the choir, know what a valuable service that ethics consultants offer to the hospital and to the patients and families and to the medical team. But I think at some point, there's only so much that goodwill can garner. And I think you need to have support from the hospital in one way or the other. So one way is financial. And so, we have been able to negotiate, one full FTE for clinical ethics. And so that is split up between our five ethics consultants, as well as some for administrative support. But it depends on which institution you're at. You may not need a full FTE, or you may need 2 FTEs, depending on how busy the ethics consult service is. You also need departmental support, because if your ethics consultants are from critical care or from surgery or whatever discipline they are, they will need to take away some of that time and dedicate some of their clinical time to devote to ethics. And so you really need buy-in from their department chair or their division chief to allow that to happen. And usually the financial aspects are going to be what drive that discussion. Right? And then also you need support from the ethics committee themselves in terms of providing resources, education to make sure that the ethics consultants feel supported, they feel equipped to be able to do a good job as a consultant. I think recognition is important. I'd like to think that all of us do it because of the altruistic nature that we all have, but I think recognition also goes a long way. And if we can build in to the promotions or to kind of performance review, that's I think most of us get as clinicians, and to make sure that they get credit for the ethics work that they put in. Again, it's a valuable service to the hospital and to patients. And then finally, accountability. And I think it's really more for maybe the patients and the healthcare system on the whole, but also I think it's an added benefit for the ethics consultant as well, to find areas how we can all improve in the consultation service that we're providing. And I'll talk about the peer review process as well. So this is what we've kind of come up with, and this is based on some resources that are available through the VA system. So they have a pretty robust kind of ethics consultant database and resources, but we've kind of adopted that for our own here at Loma Linda. And just, these are the areas that we have decided every couple years, we kind of have each consultant pick a couple cases, maybe, some that they struggled with or some that they thought they did really well on. And just as a group kind of evaluates how well they did in each of these domains in terms of, can they clearly articulate the ethical question? Did they, how do they collect and assess the relevant information in the consultation? How is the ethical analysis? Did they, address the pertinent points and the ethical questions at hand? How did they kind of incorporate all the different dimensions, cultural, spiritual, legal, social, etc.? And then the communication and the documentation. Was it done at appropriate time interval? Was it done clearly? And was it helpful to the team ultimately? And so it doesn't take very long, but I think it's something that is important for us to do and to document and to show, again, the hospital that we are taking this seriously, and this is not just something that we just do off the cuff. So again, that's kind of some of the practical things that we're doing for the clinical ethics consult service portion. But if we want to go deeper, kind of below the surface on preventive ethics, again, equally important, probably a lot more work. And fortunately, I have excellent colleagues who are passionate about this kind of area of work, such as Dr. Yi here on the front. in terms of policy processes to support the whole system and our physicians and medical team. So things such as redesigning work processes, working with IT to create decision aids, decision support, implementing checklists, developing policies and protocol that promote ethical practices and decrease or diminish moral distress for nurses and our providers. Designing education for patients and for staff, equally as important, to address specific knowledge deficits. And I'll go into how we do that and why as well. And also motivating and reinforcing ethical practices among staff. And that can be done one by one individually, but that will take a lot of time and resources. But we can create kind of more global education and resources available to all of nursing, for instance, or all of the hospitalist service or critical care to really reinforce and continue these discussions and answer some of the difficult questions that they may be dealing with. So the Clinical Ethics Committee, I think, can do a lot to help support and not only kind of providing oversight for the Clinical Ethics Consultation Service, which we provide on a 24/7 kind of basis here at Loma Linda, but all of you may not have the resources to be able to do that. I think for the most part, probably most hospitals will, have those resources available at least during the day, during normal business hours. But I think now, even on weekends, sometimes, very rarely, we get called or paged for kind of an urgent issue. I think what's very, very important, and what I would encourage you all to start doing, if you haven't already, is coding of cases and keeping track of the types of consultations that you are receiving. And I'll go into that in a little bit as well. But some examples of what our ethics committee has done in terms of preventive ethics and structural support has been revising and creating policies and guidelines regarding termination of a pregnancy, death by neurologic criteria, a protocol for organ procurement agency interaction with patients, family, and staff. And that's still an ongoing issue. We haven't resolved that quite yet. The COVID response and allocation of resources, as was mentioned earlier. I'm sure all of you were involved in one way or another regarding that. And so I think that is a continuous process. And again, not an emergency issue or fire that needs to be put out right away, but very, very important that we keep the ball rolling on those areas. Because over time, there is a need to revise some parts of that as things change over time. And our committee does a really good job of reviewing policies every few years to make sure that they are still aligned with our mission, values, and providing the desired outcome that we want for our patients. And then finally, in terms of education, I think that's the fun part for me. Really putting together conferences for grand rounds. We have a bioethics grand rounds, and also this Adventist Bioethics Consortium, and this conference I think is really one of the highlights of the year, to be able to meet with like-minded individuals, experts in your own respective field, and to share ideas and to grow and learn from each other. I think there's no reason not to share the resources that we have, the tools and tricks that we've come up with. And so I'll be sharing a little bit of what we have here, but I'm sure all of you have even better ideas and things that you're using at your own institutions. But I think probably one of the most important things in terms of education is to continue to train future clinical ethics consultants, future leaders in ethics, future chairs of the ethics committee, because we can't do this forever. Some of you may have been doing this for years and years, maybe even decades, but we need to train the next generation to pass on the baton and pass the torch. And I think it is a wonderful, rewarding field, as many of you know, but we just need to help mentor the next generation to do that. And so here we have, like I said, the Clinical Ethics Case Conference, which is one avenue. We have the Master's Bioethics program here at Loma Linda, which is very popular among our graduate students. And also we are kind of working on, we have had a pathway for practicing clinicians to do a clinical ethics fellowship and become a credentialed clinical ethics consultant as well. So this is the coding system that we use here at Loma Linda. So this is based on the Armstrong clinical ethics coding system. There are many, there are probably a handful of coding systems out there. This is just one that we felt was very comprehensive and fairly easy to use. Although you can see the list of all the different kind of topics of ethics cases that could arise. And so far, I think this is a pretty comprehensive system because we haven't had a case where we're like, I don't think there's like a great, category for this. But really the main areas are treatment decision-making, substitutive decision-making, end-of-life issues, professionalism, reproductive ethics, death and postmortem, resource allocation, research, and organizational ethics. And if you look at kind of on the column to the left of each category, you'll see in the past year how many consults we had in each of these categories. And so a vast majority are in treatment decision-making. We have a policy here for unrepresented patients. And so substitute decision-making, there's a lot of cases for our unrepresented or unbefriended patients. And also we have a policy for termination of pregnancy where a lot of consults for reproductive ethics as well. But we have a smattering of other issues, futility or inappropriate or non-beneficial treatment, and kind of organizational policy that goes in line with the unbefriended patient, unrepresented patient, and termination of pregnancy for the most part. So I think just keeping track of the number of consults and the types of consult clues us into what areas of ethics our medical teams are struggling with, and what areas we can maybe offer some more education. And again, see the next year if that education has helped, decrease the number of consults, or sometimes it increases the number of consults. But I think it gives us an idea of what we need as an organization to help support our patients and our staff. Any questions about this particular coding system? Yeah, sure. Yeah, happy to give you that. And then those of you, so I'm not an expert at kind of IT or or technical stuff, but I think there are a lot of useful tools in Excel. This is just an Excel spreadsheet, and as we're coding these cases and reviewing them each week, there's a way to just automatically, it just tallies in the type of cases that we're doing, and then we can just kind of see what the needs are and what kind of consults we're getting. Yes.
About how given case is classified, or are there ever reclassifications?
Mm-hmm. Yeah, great question. So as we're discussing the case, kind of at the end of each case, we kind of discuss, all right, we're going to classify it as this, and this. And usually in each case, we can classify, there may not be just one topic. So there might be 3 issues. And so we will discuss that and kind of come to a consensus and classify that. We haven't really had the time to go back through those and reclassify them if need be. But I think we do a fairly good job, having the ability to name up to 3 different categories. We have kind of a principal category and then some secondary ones. But yeah, it is usually done with consensus. Great question. So with that, each year we can review, how many cases, how many consults we're getting. And so you can see, starting from 2016, we had 60. And then over the course of a little more than 5 years, we've almost tripled, the number of consults that we see each year. And I think part of that was because of some of the policies that we had created in the interim. that kind of necessitated ethics consults. But I think overall, we see a steady increase in the number of ethics, which I think to me is a good sign, because it shows that our physicians, our nurses, patients, and families are aware of this resource available, and they are asking for it more often. And then we can also break it down by topic. So what are the most common topics that ethical questions that are being asked? And so again, this is kind of percentage of cases, treatment decision-making, organizational ethics, which again really has to do with the policies that we have, substitute decision-making, which for the most part are patients that can't make decisions for themselves and they're unrepresented, and then reproduction, and then end of life, and some other issues as well. And then we can also review which services are requesting ethics consults. And so I think no surprise, internal medicine is probably one of the busiest departments, and they have the most requests for ethics consults, followed by maternal fetal medicine and OB-GYN with kind of the reproductive ethics, and then the critical care team close behind, and then everyone else, kind of a lot of the subspecialties, surgery, neurosurgery, etc. Yes. They can, but I'd say it's very, very small. So there was, in this, actually, we don't, when we looked at our data, we don't have a mechanism that automatically shows who, I guess, requested if it was a family, because typically if the family requests it, then either a nurse or the case manager or the social work will call us, to do that. But I'd say for the most part, it's pretty rare, but we have a handful, maybe less than 5 or 10 a year, where it's the family that's requesting an ethics consult. Yeah. So the other metrics that we look at, and I'm continuing to, we're trying to add to kind of the metrics, and we've worked closely with our IT team and try to pull out data from, Epic to see areas that we can improve. So in terms of time to consult, I think most of, the general guidelines nationally is if you can see an ethics consult within 24 hours, I think that's reasonable. Sometimes there's more urgent cases. But our kind of median time is about 30 hours, and part of that is because that's from the time that the ethics order is put into the chart. It doesn't mean that they called us or made us aware, right? And then by the time we are made aware, usually we will address it and put a note in within 24 hours. So there's some room for improvement there in terms of how the team notifies us as ethics consultants. If you look at the length of stay of these patients, I think you can see that probably, a lot longer length of stay on average. And it's not because, I think this is an association, not a causation. It's not the ethics consult causing them to stay longer, but these are probably the sickest and most complex patients usually that we are consulted on, right? In terms of ICU length of stay. And if you even look at mortality, a third of the patients that we're consulted on will not survive, more than, 60 days outside of the hospital, or not survive the hospitalization. So these are data that we can take, examine, and try to find areas to improve on. And also, more importantly, take to administrative leadership as well, right? To make sure that they get buy-in and say, these are areas that are important to us as hospital leadership. How can ethics help us to improve in those areas? Yes. Yeah. Yeah. Great question. Yeah. So the question is how far back do we have the data? And I think we have the actual ethics consults available for, I think, maybe like 10 years, probably going back at least. But we've started using the Armstrong coding system only for the last 3 years. And so I think, I'm waiting for a good master student to go through and categorize all this data for us so that we can have it and analyze it. But we do, from here on out, we are kind of prospectively keeping track of this so that we can continue to use this going forward. Yes.
This calls for the ceremonies
Mm-hmm. Yeah, great question. So the question was, when do we include the code into the coding system? And so any ethics consult, even if it's a follow-up consult, it generates an ethics note. And so we have a formal note, a template that we use. And so anytime there's a note, that gets discussed in our ethics case conference, and it gets coded kind of separately. So there will be some repeats in terms of the same patient, and they may be coded the same, they may be coded differently as well. All right. Oh, so just going back. So other things that I hope to look at as I was listening to the phenomenal presentations in this conference, I think certainly we need to look at kind of patient demographics, healthcare inequities, and track that as well to see, are we helping improving the quality of care to those who are marginalized, who are known to have healthcare disparities and inequities. And I think that's something that I think hopefully hospital leadership will want to know, and that we can make a difference in as well. And so I'd say when approaching leadership, administration, I think data is power, right? And I think it's not just enough to say we're doing a good job and you need to be ethical, but they really want data, and I think that's what drives a lot of the decisions that they make from the top. And so for me, what's really been helpful is having a liaison, a partner in administration who is kind of a champion of patient quality and has a strong interest in ethics. So fortunately, we have one here, Jim Pappas. And so I have regular meetings with him to make sure that I'm understanding what admin wants, what they're interested in, and also for me to report back to him and admin to say, these are the things that ethics is providing for the patients and the hospital. And having that continued dialogue, I think, is very, very important. And then we present also to the patient safety and quality committee regularly, so that, again, they know and they're aware that's, the amount of work that we are doing and what we're contributing to patient care. So, it's probably very difficult to show any direct financial benefit for ethics consultation, but, talking to at least, Dr. Pappas, our liaison, he always says, what, the clinical ethics consultation service is the best bang for the buck that this hospital is spending, right? 1 FTE for all this value that ethics is providing in terms of ethics consultation, education, policy, and the support for the medical team and the providers, and you can't really measure that substantially. But these are kind of some of the other deliverables. So I don't have any concrete data, but back at the University of Chicago, they would always say, at least at that time, they said every single case that had an ethics consultant involved in that case, they have yet to have a lawsuit kind of filed for that case, right? And again, look at the types of cases that we are being drawn into. These are the most complex, sickest patients, and to have that, to be able to say that really is truly amazing and a testament in the importance of the ethics consultation service. And I think if that doesn't get the attention of the administration, I don't know what will. Obviously, we can't guarantee that there won't be any lawsuits, but I think we all know here that the one thing that is the best way to mitigate any lawsuit is just good communication, right? And I think that's what we do best, and that's what we can provide. Just getting people, the appropriate stakeholders in the same room and talking about the same thing, the most important thing, which is the patient, right? And so, and again, as I mentioned earlier, in terms of provider support, moral distress is a real thing, and physician burnout is a real thing, and it's only getting worse. And I think we found that it's tremendous help for them to hear that ethics has their back, for some of these difficult decisions that they're making. And I think it's important to them and for nurses as well, when they face moral distress in terms of, are we doing the right thing for this patient, and helping them to kind of see the different facets of the decisions and and why the team might be doing what they're doing, why the family might be doing what they're doing. I think that's important. And just even acknowledging that there is moral distress. And then again, education and policy. And I won't get into that. I think that's pretty self-explanatory. But again, I think here we are all part of the same overarching, organization. And so the same missions and values. And so why not share the similar policies? Why reinvent the wheel wherever we are? I think we can share from our wealth of wisdom and our experiences. And I don't see any reason why we need to have separate policies for every single thing. And can we work together to do that? And same with education as well. I think the one silver lining from the whole pandemic is, the boom of Zoom and the ability to just network, with a click of a button, on your computer. And so really taking advantage of the resources and the wealth of knowledge that's out there. I think that's something that we can continue to work on. And so for our providers, so for our physicians and our nurses, so I wanted to know, I like to think that the service we're providing is helpful, but is it really? And so again, I got data. And so we created a survey and we got buy-in from all the different leaders of different departments. And we reviewed the survey, make sure everyone felt like it incorporated all the appropriate things, and we sent it out hospital-wide. And I think we got about 300 responses, which was pretty good for the first kind of iteration. And so those who responded, so the first question was, I have requested or have been involved in a clinical ethics consult in the past 2 years. And so 60% of the physicians who responded said they have requested or have been involved in a consult, ethics consult. Only 17% of nurses said the same, which was really eye-opening to me. And then about half of the social workers said they requested or they have been involved, but the numbers were pretty small, as you can see there. So then follow-up, those who did request or were involved in clinical ethics consult, we said, is the support that we're providing, is it valuable? Do you feel like it helped improve the quality of care? Did the ethics consultant show respect for the clinical team's opinions? Did the ethics consultant provide demonstrate expertise in ethical issues? Do they adequately address the ethical questions of the clinical team? As many of you know, when you get clinical ethics consults, sometimes they don't really ask, you have to clarify what is the actual ethics question that you're asking, right? And they don't really know. They don't know how to articulate it. And sometimes we help them to kind of articulate what the ethical question is. And then you see that aha moment in their mind. And then did we respond to consult requests in a timely manner? And I think fortunately, I think the red kind of is strongly agree. The purple is agree. And so I think the vast majority of those who were involved in ethics consults agreed that the service was valuable. And I think that's important for hospital leadership to see. And then also follow-up questions, communication, facilitating communication, offering clear and helpful recommendations, providing education, and just the overall experience with the ethics consult service, and how likely are you to consult clinical ethics in the future? And again, vast majority, very, very likely, extremely likely, very positive overall. The interesting thing was when we looked at the data with those who haven't been involved in clinical ethics consultation, it was very, very different. It was kind of more just across the board. And so I think that told us that we need to do more education in terms of the availability of ethics consultants, what we can offer, and reach out to those who haven't utilized it or may not be aware that it's even there. And so we kind of put together some goals based on the survey results, based on the data that we collected in terms of our clinical ethics consultations. And so these are some of the things that we're working on for this year, facilitating the consult request process to decrease the time to consults, increasing nursing engagements with clinical ethics, decision aids and policies to decrease moral distress and facilitate patient care, identify areas to improve equity in patient care. So couple of cases that the data didn't really show, but that just anecdotally, we had a couple of patients that were unrepresented, who couldn't make decisions on our own, but they were psychiatric patients and with concurrent medical issues. And so they were too sick to go into our inpatient behavioral medicine hospital, but they had too many psych issues for us to be able to manage well here in the hospital. And they were kind of stuck in limbo, and there wasn't really a good place for them. And so how do we care for those patients who are really marginalized? There isn't good kind of structures and systems in place for them. Or those patients who are seeking or needing a termination of pregnancy, but don't fit our policy here. How do we make sure that they can get referred to appropriate care in a timely manner? And so those are issues also that kind of have come out through review of our ethics consultations. And then finally, to train additional clinical ethics consultants. I think that's an ongoing need and something that I think we always just continue to do, because ethics consultants, we are a rare breed of people out there, and there's always going to be a need. If you look for job postings, there's always plenty of job postings everywhere for clinical ethics consultants or directors of ethics. And so I think we need to make sure that we are training the future. I think we can never have too many clinical ethics consultants. And so this whole, kind of process, really, in terms of process improvement, it's really based on the DMAIC model or Lean Six. Many of you may be aware of that, but really it's defining the problem and quantifying the problem, which is what the data is for, analyzing the data, and then coming up with a plan to improve. And then that improvement portion, we can't do it alone as an ethics committee. We really need buy-in and support from the leadership. Well, we need buy-in and support from those who are requesting the consults, the physicians, the nurses, and to kind of identify areas that we may not even be aware of. And then implementation and control. And so kind of fine-tuning and then repeating the process, again. The nice thing is it's a continuous cycle. So always room for improvements there. And so again, I think a lot of ways to work together and collaborate and to improve the quality of care that we do, support the ethics consultants. And there was a lot of kind of work that went in on the front end to create kind of these metrics. But now that they're made, all it takes is a few seconds to email it out to you guys, and you can kind of start using it, right away. And so I think that's the beauty of this process. And you may even make it better and send it back to us, and that'll be phenomenal. So with that, that's kind of a brief overview regarding what we've been working on here at Loma Linda. I'd like to, happy to open it up to questions and also suggestions. If you have any ideas in terms of what you're doing, happy to hear those, and we can share and pool our resources and together really improve the care that we provide for our patients. Yes, Mike. Mm-hmm. Mm-hmm. Yeah, so the question is in terms of the education. And so we have a bioethics grand rounds that we provide hospital-wide on various topics. And so one was kind of based on a new policy that's, we kind of enacted for kind of a medical hold or, for kind of incapacitated patients here in the hospital. We've had bioethics grand rounds on medical innovation, certainly during the COVID pandemic, resource allocation. And so, really, I think there's a need. We hear about it, and then we kind of come up with a grand rounds to target that. For the critical care or critical care colleagues, potentially inappropriate therapy or non-beneficial therapy, which was kind of a great presentation that we heard in this conference. I think that was a big need and an ask from our colleagues there. And so we did a conference, kind of a panel kind of talking about that and continued education regarding that. And then also our Masters of Bioethics program here. I think we have phenomenal partners in the School of Religion, and on the clinical side, so really gives them the best of both worlds to understand the principles and the actual bedside application for clinical ethics. And then I'd like to kind of bring back the clinical ethics fellowship for practicing clinicians. And I think collectively, for all of us here in the room, I think we have the expertise to be able to address different ethical topics and share like a 1 hour lecture on different ethical issues and really cover the whole gamut of clinical ethics. Yeah, great question. So I think we created a brochure for families who are kind of going through the dying process and are interacting with kind of organ procurement, agencies, because they're kind of getting mixed messages, and and unfortunately, some of the organ procurement agencies can be pretty aggressive, to some of our patients and our staff. And so we've kind of created some education material for them to kind of let them know what their rights are, but also what legally is kind of required and how we can support them. I think that was, one kind of specific instance. I'm not aware of any kind of general education for patients per se or families, but I think that's a great idea. And we can look into kind of what the needs may be and give them that education. Yeah. Mike, did you have something that you want? Mm-hmm. So what do you do? Yeah, that's a great question. Yeah, so for those who are on Zoom, the question was, how do we teach our learners here, our trainees, about kind of some of the hospital metrics, such as length of stay and patient outcomes, et cetera. It goes hand in hand with, I think, kind of organizational ethics. And we do teach them that, although it's a challenge because like there's more and more every year to teach our trainees. It's not just medicine anymore, it's kind of a lot of the other things as well. But I think it's equally as important. I didn't learn that in residency. I had to kind of learn that on the fly as an attending. I'm still learning that, but I think it's important and incumbent upon us to train our students and our residents to be aware of those things, because it's real life. And so we do that, at least in the surgery department. We do that. We have our monthly QI, quality improvement meeting, and we talk about length of stay. We talk about kind of outcomes and complications and things like that. We talk about kind of the quality measures that the hospital is looking at. So at least they're aware of that. Yeah, I think those are important things to do. Yeah. Yeah. So that's a loaded question. So yeah, I'm only kind of aware of my experience here and at the University of Chicago. In both places, I think we were blessed with a lot of resources and great colleagues to kind of work together with. So, whenever I am faced with a challenge, I just load the boat, and get other people's opinions. And so I have great colleagues that I can bounce ideas from, and we can work, through it together. Not all places have that, but like I said, now, with technology, why not? Why not? We're just a phone call away or a Zoom call away to kind of discuss challenging cases and issues. But I think seems like every day when you think you've seen it all, there's always a new case that's just like, wow, I've never seen that before. And so I think we continue to learn, on the fly, and we learn together. But I think just having, I think people to kind of bounce ideas off of is helpful. Knowing that you have support from the hospital and administration, I think is very, very helpful. And ultimately, you get feedback from your colleagues letting you know, we appreciate what you're doing, and that was helpful. I think that's, I think that, and from patients as well too. I think that's really kind of where the rubber meets the road. But yeah, I don't have any magic or secret tips or tricks to that. But I think as an ethicist, I think we're continually problem solvers. We're kind of managing conflict. And so I just say maintain humility, and just keep the patient's best interest in mind, and really take the time to listen. I think that's really the most important characteristics. I mean, you can have all the credentials you listed above, but if you don't have those things, those attributes, then I don't think you would be the most effective ethics consultant. Yeah. Yeah, I wish. I mean, that would be, I mean, that's kind of one of my wish list things to do. Typically, yeah, it's a sensitive area because, like I said, majority of these outcomes aren't, patients don't end up surviving. And so it's sensitive to kind of reach out to them and ask them, during kind of a sensitive time. I have to think about kind of ways that we can maybe do that, to follow up down the road. But we also have, like a patient relations kind of team as well that does a lot of that. So you can maybe collaborate with them to see if there's any correlation, with that and ethics consult services. But yeah, I think that would be great to have. So if someone has any mechanism to do that, I'd be really interested to hear what you guys are doing. Yeah, Gina. Yeah, perfect. Yeah, that's a perfect example of we can collaborate and work together on that. And I mean, the model that I was kind of trained in at the University of Chicago was, physicians have to be the clinical ethics consultants, right? But I think that's changing, and that's not, a hard and fast rule. And there's a lot of places where, it's PhDs, who are handling the load of the clinical ethics consultations. And I think it's either one or the other. I mean, you need to be kind of facile at both the principles of ethics, kind of the theory and the principles, but also understand the clinical kind of aspect. You don't have to be an expert. I don't think you have to go to medical school to be able to understand some of the terminology, but I think, how do we train, those? And I think you need training in both, and it can be done. And so we just need to think about the paradigm that we're training future ethics consultants. So I don't think, even though my mentor would probably kind of, be hurt if I said so, but I think, there's excellent clinical ethics consultants that, don't have to be, MDs or nurses or clinicians. And we can teach kind of the language of medicine, and it's not that hard, I think. And to be honest, when I'm an ethics consultant, I take off my clinician hat, try to for the most part. So I try to play dumb and just say, you explain to me kind of what's going on with the patient. And then I just kind of, let them speak on the clinical aspects. And then we can just focus on the ethical piece. Yes. Yeah, no, we're not, but I really love that idea. I think it's great. And I'm on the clinical side, I'm a cancer surgeon. And so a lot of the times I'll be talking to patients about enrolling in research clinical trials, right? And I tell them, this isn't going to help you directly, but it may help someone else. And I don't think I've ever had a patient who said, no, I don't want to do that. So I think when you frame it in the right way, I think even families who are grieving, they want to make that process, something positive, out of it. And so I think I would venture to guess that probably more families than we would expect would be willing to kind of do that, spend a few minutes to kind of help improve the experience for the next family who's going through that. But yeah, thank you for that. But any other thoughts about I guess chaplains who are in the audience, how you kind of balance that role or not at all, maybe just embrace both sides, as your yeah. And that would be great to collaborate, all system wide regarding that. And I think it would make sense, with our organization, our church, we should be leaders kind of in that field. Ideally, that would be great. Yes.
Yeah, I'm thinking of a research that was done by the Balbonis. It's a book that was referenced by, I think, Dr. Yishen at the plenary session. It's a few years old, but it shows that there's this relationship that the higher a family is in the religiosity scale, at the end of life, the more invasive and radical procedures they're going to request. And the Balbonis came here and presented that actually a couple years ago. And it generated, I think, quite a bit of conversation about why is that. I think it was Dr. Who was it that came and presented? Macaulay? I think he came and presented on that chapter. But the argument that he was making is that this is why spiritual care is actually essential at the end of life, especially at the end of life, because it helps people guide them through difficult decisions. Whereas if they don't have somebody who's trained clinically or professionally, and it's just the faith community guiding, sometimes the decisions are misinterpreted or misunderstood as like the more invasive and radical you get, the more faith you have in God or something like this. And so, the presenter was kind of exploring, the connection between the two kinds of care. Anyway, your research kind of reminded me of that paper.
Or even the converse, if you kind of give up, then maybe shows your lack of faith, right? So, yeah, absolutely. I think that's something that, our chaplaincy colleagues can really help those who don't have that spiritual training, that background, because I think it's becoming more and more important. And I think to provide the care that patients need and deserve, I think we need to be able to be facile at dealing with those issues. I agree. Yeah. Mike. Yeah. Thank you for sharing. And I think we've all probably had experiences like that, and patients' experiences like that. But I think for me, I think the takeaway is there's no shortcuts. I think sometimes people think that ethicists, we just go in there, wave our hand, and then, we can convince patients and family to do whatever we want. But we know that's certainly not the case. It just really, in all my experience, it just takes time and being present and listening. And I think one thing that I want to leave you all with in terms of, again, getting that support that you need to be effective. I think it's worthwhile to truly document, how much time we're actually spending per patient. We're not billing for these consultations. We're not getting paid for them from insurance or the family, but I think it's an investment that the hospital is making. And again, I think it's an investment that is a good investment, a good return on their investment in terms of the outcomes for patient care, the medical aspect, but also their own kind of the satisfaction with kind of the care that they received. And I think we can't expect anything less from a hospital system, a faith-based hospital system, right? We are reflecting Christ's character and his healing and teaching ministry as well. So I think we have a few more minutes. Yeah. Absolutely. Yeah, I think, and that brings to mind a really difficult case that we had a couple of years ago, and I think I can share it because it was all over the news and social media as well. But during the COVID pandemic, there was a patient that we had who was started on ECMO for COVID, and with clear explanation to the patient and to the family that really this is a hope that maybe he'll be a candidate for a lung transplant down the road or get off of ECMO, but they're not going to keep him on ECMO indefinitely. But not surprisingly, he ended up not being a candidate for lung transplants. He wasn't getting better. And the family was like, no, you need to keep him on ECMO. And so it was really, really difficult. We only had, I think, the ability to do 2 ECMOs for adults at a time. And this patient was on for months, 2-3 months longer than he was supposed to. And then to make matters worse, there was this whole social media campaign and picket signs, in front of the hospital saying, how we're trying to kill, their loved one. And so it was a lot of distress for the team who was trying to do what was best for the patient. And so I think absolutely, a big part of what we do is to support, our colleagues as well in those times. So, all right. Any other questions or comments? Really appreciate you guys all sharing your experiences and it's really, thank you for making this session really interactive. And I certainly learned a lot, and hopefully we'll continue this conversation and continue this collaboration as afterwards. All right. Okay. Thank you all.